All right, so our goal today is to review all of the LGBTQIA plus family building options at SRM, answer any questions you'll have. Good to remember that, of course, treatment plans are ultimately tailored to the individual person and couple. So what we review is just kind of an overview, but your specific goals will be addressed at a new patient visit with one of our providers. During the talk, I'm going to refer to anatomic terms such as sperm, eggs, uteruses for the different sections. Okay. So what to expect when you see us here at SRM. The first thing is we are going to ask about your specific goals. We know you're an individual, each couple's different, each individual is different. Everybody has different goals and what they're looking for. Are you looking to conceive? Are you wanting to preserve your fertility and in hopes of having children in the future? What does your ideal family size look like? Are you needing donor gametes like sperm or eggs to potentially need a gestational carrier to carry the pregnancy? We will ask you what your name is and your pronouns, so you can be assured of that. And then we will also help you develop an individualized treatment plan. We know that the road to building a family, especially when we have to use donor sources or gestational carriers and things like that, can be kind of complex and sometimes stressful and overwhelming. So we're here to guide you. You'll have a whole team of people working with you, from physicians and nurse practitioners as your providers. You'll have nurse coordinators, financial counselors. Annika's on the line with us today, so any financial related questions, she'll be available for that. We also have genetic counseling, mental health counselors, wellness resources, nutritionists, acupuncture, all the things, okay? So first thing we're going to talk to, first section, we're going to talk about individuals and couples who have eggs and uteruses, okay? So what are the options for those who have eggs and uteruses? There's several different options depending on which approach we want to go. The first is intrauterine insemination, where we take either sperm from a partner source or from an anonymous donor or a known donor and put that in the uterus at the time of ovulation, whether we use medication or just natural timing of a cycle, and have a pregnancy that way. Or a little bit more on the invasive side of things are in vitro fertilization, where we stimulate the ovaries to develop eggs. We take those eggs out at the very specific time, create embryos in our lab, and then transfer an embryo to either the patient's uterus or partner's uterus. And similarly, reciprocal IVF is where we do IVF, take the eggs from one partner when both partners have eggs and or uteruses, take the eggs from one partner and then create embryos and transfer that embryo to the other partner, okay? For sperm sources, for any of these options, you can use an agency donor, which means a sperm bank. You can use a known donor if you have that in mind. And then if you have a partner with that produces sperm, you can use either frozen sperm or fresh sperm, depending on the situation, okay? So this is just that reciprocal IVF, what we call shared maternity or shared IVF, where basically this is what a classic IVF cycle looks like. The person who is carrying the pregnancy will have eggs retrieved, create embryos, and then transfer back to that same person. Whereas with the reciprocal IVF, there is the genetic parent is the egg source. We retrieve eggs, create embryos, and transfer that embryo to the gestational parent, the person carrying the pregnancy. Okay. Now, a lot of the questions I get at first initial visits is about donor sperm. So like I mentioned, there are donor banks, and there's the option of using a known donor. There are pros and cons to each. When you're deciding which is best for you, there's several things you want to consider. Cost, of course, is on top of mind for most people. Quality of sperm and safety too, as well as the diversity of choices. Everyone has their specific things that they're looking for a donor, whether it's to look like your partner or different, all sorts of different things that people are looking for. So that's important. And then also the information about the donor. Some people are, they're really interested in their donor. They want to know everything they could possibly know about their donor. And other people aren't quite as invested in the specifics. Other things to consider, and we'll go into in a little bit more detail, are when you're looking at a donor bank or using a known donor, we look at their cytomegalovirus or CMV status, and we'll talk about it. And then we also look at if they're carriers for specific diseases that might play a role in pregnancy. So those are called autosomal recessive carrier diseases. These are things like cystic fibrosis or sickle cell disease, things that you could potentially pass on to your offspring. Okay. So going towards the donor bank first, the first thing that we look at for banks is there's lots of options out there. You can have your options. There's different banks. We'll show you a list of banks that we work with at SRM. We use banks that follow all the FDA guidelines, and we are checking in with them to make sure the guidelines are still being followed. So we have a specific list, and it gives you a lot of options. There's 6 that we work with. So we're talking thousands and thousands of potential donors. The testing and screening is done up front. So what happens with a donor in a bank? They come in, they get physical exam, personality testing, genetic testing, physical health history, all of the things, and then they actually get tested for infectious diseases, things like hepatitis, HIV, gonorrhea, chlamydia, things like that. Then the donor, they do some collections. That sperm, those samples get put on quarantine for 6 months, and that's called quarantine. So at the end of that 6 months, the donor has to come back and be retested for those infectious diseases. And that there's certain things like HIV and hepatitis that have a latency period, so they can come up positive over that 6-month time period. Of course, if the donor is positive, they're not allowed to be a donor. If it's negative, then those samples that had been on quarantine are released for purchase. Okay, so with a donor bank, that quarantine period has already been completed. So there's no waiting for your samples. So that's a benefit to using a sperm bank. Donors do sign disclosure agreements, whether they would like to be contacted or not in the future. There are different Washington state laws for disclosure, but donors, you can pick a donor based off of the disclosure agreement. Okay. You have the ability to switch donors if you need to, which sometimes is important if we're not getting results with one donor or the samples aren't as quality as we wanted them to be. Most banks do have a guarantee for the certain number of millions of sperm in each vial. That is something you want to make sure you're looking at when you're choosing a bank. What is their guarantee, and what are their protocols for how if you needed to use that guarantee, how does that work? Now, most donor banks, their samples tend to have higher concentrations and better quality sperm than people that use known donors, and that's because they've been screened. So those with poor quality sperm samples are not allowed to be donors for donor banks. So you're in general going to have higher quality sperm at a bank than if you just have some person, if you just picked a person off the street, their sperm counts are more likely going to be lower than a donor bank, if that makes sense. But that being said, I've had known donors that have perfectly great sperm, and we wouldn't know that until we do like a semen analysis. Okay. You can choose a donor who has had good pregnancy outcomes in the past. Sometimes that's helpful for choosing a donor. On the con side of things for a donor bank, the diversity of the donors can be lacking depending on the bank. Some of the bigger, more national banks, that's not really an issue. You have lots of options, but some of the smaller banks might not have quite the diversity of donors you're looking for. Inventory may run out. And I've noticed that this year, I've had more people tell me that their donors are running out faster than usual. I don't know if it's a COVID thing, like maybe people are getting donor sperm and getting puppies. I don't know, but it tends to be running out more quickly now. So that can play a role, especially if you're heavily invested in one donor, how many vials of sperm you want to purchase ahead of time. There may be several different families that use the same sperm bank or sperm donor. So that's something that some people find problematic. Other people kind of like that idea. And there's even Facebook groups and things that have donor siblings, and they are supportive of each other. So that's awesome. And some people really do just want to know who their donor is, or maybe it's a sibling of your partner or something like that, in that situation in which a known donor makes more sense for you. In most cases, a donor bank donor is not able to be contacted by a family until the child requests it at age 18. So that's another potential con, okay? Especially if you want that donor involved in your child's life. Okay, so sperm banks, these are the list of the sperm banks here that we use at SRM. The local banks, Seattle Sperm Bank, Northwest Cryo is in Spokane, and then the other 4 down here are more large national banks. They're all great. We have great relationships with all of them. Okay, and they conform to ASRM and FDA guidelines and regulations. They're certified. We make sure that these are all up to date quite regularly. Okay, so using a known donor, the pros of that is you have the ability to use a partner sibling or relative. If a genetic connection is desired, you know your donor, you know their traits, their personality, their talents, them as an individual. The child can have a relationship with the donor if that's desired and that's what you have all agreed on. There is an option for co-parenting situations in that case too, okay? Cons, the steps that the donors at a bank have already gone through have to be done for a known donor. So typically this means that there are more steps and there's more time involved before we can do any kind of treatment plan. We have to have a legal contract in place. We need to do counseling to make sure everybody's on board and that legal contract is agreed upon. And oftentimes the FDA is requiring that we're doing a physical exam and blood work, all of those infectious disease testing and things on a known donor. So it can be a longer process. Now, and in most cases, a quarantine is recommended. So that's a 6-month period where we can't use that sperm until the quarantine is complete. In some circumstances, the quarantine can be waived. So that's a discussion with your nurse and your provider because it's very individualized. It just depends on the situation. Because of all these hoops that you have to kind of jump through with a known donor, it tends to be more costly because you are having to pay for all these tests for your specific donor. And then the involvement with a child, the desire for that can change over time because we're all human, our relationships change, we change as people. So that's there. That's why a legal contract, a legal agreement is very important in these situations. Okay. And like I mentioned before, there's the potential for less quality sperm. Okay. So cytomegalovirus, this is what I had brought up earlier. When you go onto a donor bank website, you're going to see this donor is positive, CMV, this donor is negative. It is a virus that affects, over half the population in America. And it's kind of like a stomach bug. It's just a virus that you get. You wouldn't know you had CMV in the past unless you were tested for it, versus any other kind of stomach illness. But it is transmitted through body fluids. And it's a virus that can cause birth defects in babies if you get it while you're pregnant. And so theoretically, a donor who is positive for CMV, meaning they've been exposed to it in the past, they have those antibodies, and they potentially have that CMV in their system. If you are negative and receive the donor sperm, potentially you could contract CMV, and then if you become pregnant, you can pass that on to your fetus. Now, the risk of that is extremely low. But we do recommend choosing a CMV negative donor if you're negative for CMV. If you're positive, that means you've been exposed before. You can choose a positive or a negative donor. I always preface it like this though. How many people are out there getting pregnant and their partner, they don't know their status, their CMV status, right? Of their partners. So the risk is very low, but because we know there's a potential risk there, we usually recommend CMV negative if you are negative as well. So, but again, this is something that you would discuss with your provider to talk about a little bit more if it's applicable for your situation. Okay, so recessive carrier disease screening. These are things that you carry on your DNA. You don't necessarily have that disease yourself. You just carry it, and you can pass it on to your child if you and the donor are both positive for the same illness. So cystic fibrosis is an example. If you're a carrier for cystic fibrosis and the donor is also a carrier for cystic fibrosis, that same gene mutation, you have a 1 in 5 or 25% chance of having an affected offspring. So this is one thing that oftentimes when you meet with your provider, they're going to recommend that you get screened, or the person who's receiving the donor sperm gets screened for recessive carrier disease screening testing. So the donors at a donor bank get screened for like 200 plus of these carrier diseases. And if you get screened, or the person that is whose egg is being used is screened, will know if they're positive or negative for any of these diseases. So let's say the egg source, the person with the providing the egg, is positive for cystic fibrosis, then you're going to want to choose a donor who's negative for cystic fibrosis to just minimize as much risk as possible. Okay. We do have a genetic counselor here if there's any question about any of that. Okay. So initial steps when using donor sperm, the first thing is infectious disease screening for, and this actually needs to be updated. It's just for the patient who's receiving the donor sperm. So if your partner does not need to be screened for infectious diseases if they are not receiving donor sperm. It's just the person that will be carrying the pregnancy or receiving this sperm. Okay. We talked about the CMV, preconception screening. These are labs that you would have done if you were to just go into an OB/GYN office being pregnant. There are things like blood type and whether you're immune to rubella and varicella. So those are things that are done on almost everybody, including thyroid hormone. We're a little bit pickier about the thyroid here in the fertility world. We want it to have a kind of narrower range of normal because we know that it's linked to fertility as well as miscarriage. So we check that on everybody. We also check what's called ovarian reserve. So this is the egg supply testing. So for people that have eggs, we know we're born with all the eggs we're ever going to have. And over time, we start to lose those eggs as we get older. After about the age of 35 is when that egg supply starts to drop a little bit more rapidly, but it's different for everyone. And there's kind of like a bell curve. There's people that are above average, there's people that are below average, and there's kind of people where they should be for, their age. By doing ovarian reserve testing, we can tell you where you're at for your age, and it might change your treatment options. Okay. Uterus and fallopian tube evaluation. So oftentimes we're doing ultrasound. These things are things we don't necessarily do on everybody. It is very individualized. Some people have higher risk for having like blocked fallopian tubes or having a uterine abnormality. So this is definitely something that is discussed with your provider, whether it's something they recommend or not. But ultrasounds are relatively common. So that's basically looking at the structure of the uterus, looking at the ovaries. It's one way that we can look at your egg supply. This is an example of what an ovary looks like. So these little black dots are called antral follicles. They're little resting fluid pockets where there's resting eggs. That is a key part of ovarian reserve testing. This hysterosalpingogram, or HSG, this is the way we test fallopian tubes to see if your tubes are open or if you have a blockage. It also tells us about the cavity of the uterus, whether there's something growing on the inside of the uterus, like a polyp or a fibroid, or if the structure looks normal. And this is what an HSG looks like. So this is the uterus here. This is the right fallopian tube, and this is the left. So that gives us some important information. If there's something in your health history that makes us think that you might have a blockage or something, then we usually recommend this test. Or if we're not getting pregnant after a while, we're usually recommending this. But if this is the first time trying to conceive, you otherwise have no issues in your health, nothing that would make us think that we would have a blocked fallopian tube, then sometimes we can defer this test until later on. Okay. So counseling visit, like I mentioned before, when you use a known donor, you're often meeting with one of our counselors. But when you're using a donor bank, you don't necessarily have to do a counseling visit. We do have counselors available if you have any questions or you just need some support, because as I mentioned before, the fertility process sometimes can be stressful. All the interventions can be overwhelming sometimes. So if you need anything, we have counselors available. Okay, here. So this is just an example of what an insemination treatment cycle would look like. we would either monitor a natural cycle, no medication, or give you medication to increase the number of eggs that you're growing, depending on what your provider decides. You would then do an insemination where we put the sperm in the uterus at the time of ovulation. And usually we do this for 2 to 3 months, and then you check in with your provider if you're not pregnant. And sometimes at that point, we're recommending that we test your fallopian tubes, or we need to adjust anything or add medication. If not pregnant after 4 to 6 cycles, depending on the couple and the individual, we might direct our energy towards IVF if we're not pregnant yet, or if there's something that's indicating that, IUI is probably not going to work. It's dependent on everybody. Okay. Everybody's journey is different. Okay, so that was a lot of information very quickly. But this is one of my break points. What questions do I have so far?
Hi, Ruby. It's
Hey.
Marcy.
Yeah.
You have one question so far. It says, is the change in policy regarding not testing partner for infectious disease and only testing recipient, pregnancy carrier, a new ruling by FDA? If so, could you send a link to that in writing?
Yes. So the donor team might have some more details on this, but it is something that's more recent. And I don't know if it was an ASRM recommendation, because we get our recommendations from multiple different sources. And I believe it was the American Society of Reproductive Medicine, our big professional organization, that recommended that the partners no longer need to be tested. So I don't know specifically the answer to where that came from, but I can get the information for you. So yeah, we can definitely do that. Okay.
See, and one other question was, can we increase the amount of eggs post 35 years old? So after 35?
Yeah, very good question. Unfortunately not. We are only born with the number of eggs that we'll ever have. And over time, the number of eggs that we have decreases. The quality of the eggs also starts to decrease over time. But that trajectory, how quickly that happens, is different for everyone. So that is definitely something where when we get our ovarian reserve testing or that egg supply testing, you're talking with your provider about where you fall in that. And it all depends on health history and your specifics for us to give you a more detailed look of what your chances of success are based off of your numbers, your ovarian reserve testing, and your history. If that makes sense.
One other question, you may go through this. For reciprocal IVF, does the gestational carrier need to take medications?
Good question. So if it's a partner, yes, usually. It depends. If it's a partner who is reciprocal IVF, who is carrying the pregnancy, there's 2 different ways that we do what we call an embryo transfer cycle. And sometimes it follows like a natural ovulatory cycle if they have regular periods and things like that. But if there's anything else, we worry about the timing, or they have irregular periods or something like that. There's what we call a hormonal replacement therapy transfer cycle. So there's basically 2 different options, and it depends. Sometimes, they're both equal in terms of success rates, but it's just individualized when it comes to which one is best for the couple. And also when we're doing the transfer, as we're doing reciprocal IVF, usually one partner goes through the IVF cycle first, retrieves eggs, and then creates embryos in the lab. And then after those are created, we can have an idea, or if we need to do genetic testing, anything like that. After that's all completed, then the gestational carrier partner will go through their embryo transfer cycle.
That's it, Ruby, for now.
Oh, I just opened this chat too. So you spoke of increased production. So medications, yes. So when you're doing an insemination cycle, on the surface of your ovaries, you have these antral follicles, and those are little resting eggs that come to the surface every month. One, when you're not on medication, comes to the surface of the ovary. one ovulates. The rest of them that were on the surface just die off. So we actually waste a lot of eggs for the one that we ovulate every cycle, which is kind of depressing when we only have so many. But over time, that number that comes to the surface decreases. But with whatever's available on the surface is potentially, could develop a mature egg. So in a natural cycle, we usually only ovulate one, but there are certain medications that we can give to increase the number of eggs that you're ovulating every cycle. So your overall pool of eggs might be decreasing after the age of 35, but we might have some eggs on the surface of your ovaries to increase your chances of pregnancy per cycle. I hope that answers that. All right, so on to for individuals and couples with sperm. Okay. Too fast. Okay. So for those with sperm, it depends on the couple, of course, but there are the IVF is kind of the way that we need to go about this. Egg donor is an option. So if you need to egg donor sources, we have national banks. We work with My Egg Bank a lot. There's lots of egg donors there. And then we also have in-house donors. So you would work with one of our donor teams to find an egg donor. And then if you needed a gestational carrier, your partner does not have a uterus to carry the pregnancy or is not willing to carry a pregnancy, which is also legitimate, then a gestational carrier is involved. And in Washington State, we, a couple of years ago now, changed our laws that we now have the ability to have gestational carrier services. Before it had to be what we call a compassionate gestational carrier, meaning it's somebody that you know that's volunteering to carry your pregnancy. Now we actually have services that you can have a professional surrogate. So they are being screened by the agency. So kind of like a donor bank, but for gestational carriers. So it's kind of a cool thing now. There's also embryo adoption, similar to using an egg donor, but you are have the embryo there. With an egg donor, you can use your sperm or partner sperm to create embryos. When you're doing embryo adoption, it's from a different couple, okay? And can be paired with gestational carrier too. One thing to mention, when you hear about getting a surrogate, there's two different kinds of surrogates. We refer to surrogates as gestational carriers, meaning they're just carrying the pregnancy. A traditional surrogate or a traditional surrogacy is when the person carrying the pregnancy is also the egg source. And we don't do that here at SRM. The person that is carrying the pregnancy, if we're using a gestational carrier, has to be separate from the egg donor, okay? Unless it's a partner, of course. This is, we're talking about third parties, other people outside the couple, okay? See, and co-parenting, so in the cases of using known sperm donor for another individual and couple, that's something that we do as well. That would be something that we would meet with all of you as a group and talk about options for that. And then of course, adoption is an option if you're not willing to go through the egg donor gestational carrier process. Okay, it's an option for anybody, but okay. So egg donors and gestational carriers, the pros and cons to both of these, very similar to sperm donors. The egg donors also go through FDA screening, so the regulations still apply. Like I mentioned, you can use an egg bank like My Egg Bank, or you can use a known egg donor. So if your partner's sibling, sister, or cousin or whatever has would like to be your egg donor, you can use a known egg donor. Okay. Now, when you're using a known donor, same thing, psychosocial counseling, mental health counseling, where you meet together and make sure everybody's on board, have the legal contract and things like that for known donor still applies just like it does for sperm. But if we're using egg bank, you don't necessarily have to go through that. It's an option if you would like. And gestational carriers, they are also screened by the FDA. And there are screening requirements for the intended parents. So intended parents would be the individual or couple that are taking home baby, right? And if you are using your patient or partner's sperm and or eggs, whoever is transferring quote unquote tissue to that gestational carrier has to do FDA screening. Because technically the gestational carrier is receiving your tissue. The FDA requires that everybody involved in that gets screened by the FDA. Okay. And see. Compassionate GC, I mentioned that a little bit. It's somebody that volunteers to be your GC without compensation. Now we have the agency GCs as an option as well. And let's see. All right, so this is super convoluted, but don't worry, that's the gestational carrier process. And the reason I don't keep it up very long is because you will have a coordinator that walks you through every single step of the process and makes it super streamlined and easy. It just means there's more people involved in the process. There's some FDA hoops and things that we have to jump through. Don't worry, we'll walk you through. Okay. So success rates, and I didn't mention this with for those with eggs and uteruses, it's very dependent on the patient and the partners, the quality of the eggs, the quality of the sperm. So once we get all the data on you specifically, we can give you more information onto your success rate. The success rates of like an insemination are going to be different than IVF, and there's less that have to go involved. Okay, so another breaking point. Do I have any questions about egg donor, gestational carriers, anything for people that have sperm?
Yeah, hi Ruby. We don't have any questions right now.
Okay, great. All right, so next we're going to move on to, it's specific to fertility preservation for gender, prior to gender affirming treatment for our trans or gender diverse patients, but we do talk about, fertility reproduction as well a little bit. Okay, so first, when it comes to fertility preservation, when is the best time to freeze egg or sperm? And basically, it depends on you. We meet you where you're at. So if you've already started hormones or you have not started hormone, we're meeting you there. We're going to do our best to preserve your fertility for where you are at. Ideally, though, if we're talking like ideal scenario as a fertility clinician, where do I want somebody to be before freezing their eggs or sperm? Want them to be post-puberty. You've gone through puberty already, so that means that you're producing eggs and sperm. And then prior to the initiation of gender-affirming therapies. That's not always possible, and it's, that's fine. We'll talk about how that can impact things. But in an ideal situation, it's before we add any kind of hormones to the mix, mostly because we don't know the long-term impact of gender-affirming therapies on fertility and reproductive outcomes. Most everything is coming forward in recent literature has been very reassuring, but we also don't know how it impacts your ability to conceive or use your eggs and sperm. So in some cases, I'll take sperm for example, after initiating estrogen, typically you need to have a time off period before the sperm production comes back, which is very hard. Usually sperm production takes about 3 months, and that's a long time to be off of your gender affirming estrogen. Now it's doable, and I've seen people that have been on estrogen for long term and they still produce sperm, and then I've seen people that have absolutely no sperm whatsoever anymore. It's very different. I wish I had an exact, it's black and white, but it's super gray. So it really just depends on you. And the first thing we do is check and see what your fertility looks like if you've been on hormones for an extended period of time. Same with testosterone. Some people still have periods on testosterone, depending on the dose, how long they've been on it. Ideally, for dysphoria reasons, most people would prefer that they don't have a period. But in some cases, they might return to ovulation pretty quickly after stopping testosterone therapy. In other cases, it might take up to a year. Usually we're quoting ovulation and return to normal ovulatory function typically takes 3 to 6 months, but again, it's different for everyone. When we're going through, let's say like a shared maternity cycle, and one partner who wants to provide eggs is on testosterone. If that's the case, recent literature is showing it's very reassuring that we can keep on the testosterone until almost the very last minute before starting an IVF cycle. In more recent times, there was that thought, maybe we need a quote unquote flush out period, time being off of the testosterone prior to starting an IVF cycle. And in the majority of people across the country are recommending like 6 to 8 weeks off of testosterone prior to IVF. But more recently, more and more people are saying, I don't think we need to necessarily be off that long. And the honest answer is we don't have guidelines for this yet because we don't know. We don't have the studies yet to back us up for what's the best ideal situation. But so far, and again, this is a discussion with your provider, in a lot of cases, our goal is going to minimize the amount of dysphoria we're having, the impact on you personally going through an IVF cycle. And it'll just depend. We very well could, take the testosterone up to the very point of starting your IVF medications. Usually an IVF cycle takes about 2 weeks or so, 14 days or less. And then hopefully we can get you right back on that testosterone afterwards. Now, one thing to be aware of when we're going through an IVF cycle that a lot of people don't consider is a lot of what we're doing, the hormones in themselves, adding estrogen to the mix in itself can be dysphoric, even if we continue the testosterone up until the very last minute. So adding estrogen can be dysphoric. Some people have at least one period during their egg retrieval, and that can be hard. But oftentimes it's a conversation. And so if you're aware of it, sometimes it's easier to know if it's coming. And then a lot of the way that we manage our IVF cycles, we're doing ultrasounds, which typically are vaginal. I have done abdominal ultrasounds on people through IVF cycles and had really good results with that. So that's a discussion with your provider as well. We try our best to make it as comfortable and easy as possible for you. Okay. And then, of course, we want to do any kind of fertility preservation prior to any kind of surgical intervention, because oftentimes if we're removing testes or removing ovaries, it's sterilizing. You don't have fertility after that. Okay. So I just kind of gave a whole long synopsis on if you're already on hormone replacement therapy. Like I mentioned, there's no set guidelines or consensus. But yeah, recently, most people are, any of the providers I work with have been taking it really close to the IVF cycle. Okay. Now, for those that are on estrogen and spironolactone, like I mentioned, it can take 3 months or longer for sperm production to resume. For any of the hormone replacement therapy, we don't know long-term how it affects eggs. We don't know how it impacts pregnancy outcomes, although most evidence so far is showing that it should be fine. And then long-term health outcomes for children born from people that have used exogenous hormones. So far, everything's looking reassuring, but we just don't have super long-term data on that yet. Okay. For adolescents who are on puberty blockers, this is the very tricky situation. So most people, adolescents, when they seek their gender-affirming therapy, if they have not gone through puberty, one of the things that we can do is block that puberty, their natal puberty, and then use their gender-affirming hormones to do the opposite puberty. But this has an impact on fertility, because if we're not going through puberty, then we're not producing eggs and sperm. So it does play a role in fertility long-term. And it's a hard decision to make when you're like going through puberty when you're a teenager. So unfortunately, right now with the options we have, in order to preserve fertility, you have to stop your puberty blocker, go through puberty, resume the production of sperm and eggs, or have menses and ovulation, and then go through an egg freeze or a sperm freeze process. There are on the horizon right now, we can freeze ovarian tissue and testicular tissue. Now, how we use that in the future, though, is not ideal. So for ovarian tissue, it's not experimental anymore. You can freeze ovarian tissue and use it in the future. But right now, we have to do what's called auto transplant, which means transfer it back to the person, which is not ideal. We don't want all of those ovarian hormones happening for our trans and gender diverse people. But hopefully in the future, we will be able to use that ovarian tissue or testicular tissue in the lab and grow eggs and sperm in the lab to be used and create embryos in the lab, so then we can transfer them to the individual person, their partner, or gestational carrier. So hopefully on the horizon. Okay, so I won't go through all of this, but for those with sperm, for fertility preservation options, you can freeze sperm from ejaculated sperm. Sometimes that can be dysphoric. So if that's the case, we can do surgically extracted sperm under anesthesia. And then, like I mentioned, the immature testicular tissue for those prior to puberty is the only option right now. Okay. And right now, SRM does not freeze pre-pubertal testicular tissue because it's experimental. Ovarian tissue cryopreservation is no longer experimental, used for pre or post-puberty. But if you're post-puberty, the options usually are egg freezing, going through an egg freeze IVF cycle, or creating embryos and freezing embryos. Okay, so basically to summarize, like next steps for fertility preservation, for those with sperm, all you have to do is like call and schedule a semen analysis if masturbatory ejaculation is okay as an option. Now, if there's something else, you might have to meet with one of our providers. For eggs, unfortunately, it's just a longer, more drawn out process requiring medication and monitoring and things like that. So you have to meet with one of our providers to discuss an egg-free cycle. And it's usually more of a process. But either way, contact our clinic and we'll tell you which direction you need to go. Okay. So that's a lot. Questions about anything? I opened up the floor. Okay.
Right now, there are no additional questions, but yeah, feel free to add those to the chat.
Absolutely.
So Ruby can answer them while you have her. We have, let's see, about 15 more minutes if anybody else has questions.
Oh, that's great. Okay. Yeah, I usually draw out all my time, so it's great to have time for questions. There are some websites here that are really helpful if you need anything. Let's see. So I have the chat up, Marcy, so I can read some of these. Is the sperm quarantine always required for a known donor, especially if it's family member? No. Nope. So that's discussion with our donor team and your provider. There are certainly circumstances where we can waive the quarantine. Absolutely. Financing. Oh, Annika, here you are. Welcome, Annika.
Yay. Hi, everybody. I am one of the financial counselors here. So let's see, ballpark gestational carrier options. So we do have flat rate fee pricing, and for the gestational carrier screening fee, it's a $4,500 fee. There is also a coordination administrative fee that goes along with like the cycle when you're creating embryos, which is about $500. So there's an admin fee, but then the main fee for the gestational carrier to be screened is $4,500. And that applies to a known gestational carrier or agency found. Of course, if you're going through an agency, you're also paying the agency fees to be paired and matched with that gestational carrier too. Talking about financing, I see another question about that. So I guess, and I see another one about just general cost. So a new patient consultation can go up to $300 with one of our providers. All of the providers' time is time dependent. So a lot of times it's around $250 to $300. And if you do have insurance with diagnostic coverage, just like general testing coverage, consults are always billable and subject to your policy amounts. And then things like labs can vary, of course, depending on what your lab orders are. All be usually billable to policies with diagnostic testing coverage. And then things such as uterine evaluations or semen analysis, those are also testing services, so those would be billable. As a ballpark number, if you're out of pocket and there's no coverage, something like an HSG uterine evaluation, that dye test that Ruby was mentioning, that is one of our more spendy tests. That's $850 out of pocket. A semen analysis is $125. And then let's talk about sperm a little bit. So of course, the sperm cost will vary depending on where you purchase it from. I think on average, it can go between like $700 to $1,200 per vial, depending on the bank that you use. And then when we accept sperm into our facility, we do have a $200 receiving fee, $55 to store it. IUIs are usually about $500. IVF can range. So it just depends on if you're doing genetic testing on the embryos, how you're creating the embryos, is it reciprocal IVF, all kinds of different things play into the cost for that. But ballpark number, maybe about $20,000 to $25,000 for IVF.
All right, there was one question. Could you please share more on how the timeline works for IVF? Yes, so in general, for like a general IVF cycle, usually the cycle itself is on average about 10 days. Now, there is a lead up to that. So timeline, first you have your new patient visit with your provider. You discuss your goals and what the best outcome, what you want to achieve. And then your provider will set your plan. You'll have your nurse coordinator who will walk you through all the steps. And what they do initially is they help work on a calendar, what we call a calendar with you. And they look into things like your, vacation schedule, your work schedule, things like that. But also we have a lab schedule. We can only start a certain number of IVF cycles at a time. We can do a huge number of them, but we do have a limit because we only have so many lab staff that can handle all the eggs and embryos and things. So they have a calendar of people who will, they'll basically find you your date, your start date. And it depends on the situation. Some people get put on contraceptive pills, like birth control pills beforehand, not always. Especially in cases when we're using like testosterone or something for our trans patients. We don't necessarily want to use the estrogen and progesterone pills in that case. So sometimes we don't do anything at all. But what the birth control pills, it seems kind of counteractive, but what it does is it keeps the ovaries on pause so we can start your IVF cycle whenever we want to and when it's best for your calendar and your timeline and everything. Once you actually start your injections, average 50% of people take their injections for 10 days, but it can vary 2 or 3 days before or plus or minus. And then after that, your egg retrieval, is a couple days after that. So start to finish, from the time you start your injections until you have your egg retrieval, is about 2 weeks. Recovery is usually pretty quick. If we're doing what we call a fresh transfer, meaning we're creating embryos and then immediately transferring them back to the same person, then usually the transfer happens a few days after your egg retrieval. If we are then transferring the embryo to a partner, like a reciprocal situation, we can do it kind of at the same time as the other partner doing their IVF cycle, kind of concurrently. It's a little more complex with that one, but it's been done. We can do that for sure. Or in more common and usually easier logistically is to then proceed with an embryo transfer cycle after the other partner completed their IVF cycle. So in that case, from the IVF cycle to the end of the embryo transfer, it can be, a couple months or so. Okay. Are IVF meds always injections? So technically, I'm going to get really technical about it. In most circumstances, yes. For both best outcomes, most of the time, yes, it involves injections. The one thing I can tell you about the injections, though, most people are highly intimidated by them at first, but once they start them, and the lead-up process to IVF is always like super stressful and just like, I don't know how this is going to work. It's the unknown kind of thing. Once people start their injections, they're in the middle of their IVF cycle. They're like, oh, I got this. It's fine. This is no problem. And I don't know. So we usually have people come in for 2 or 3 ultrasounds during their IVF cycle. And the first time I see them after they start their injections is around day 5 or 6 of injections. And by that point, they're like, I don't like poking myself with things, but I got this. It's fine. So yeah. So in most cases, yes. Very, very rarely do we do something with oral medication. Usually not very good success rates with that. So do we work successfully with clients living hundreds of miles away? Yes. Yeah. We have people that fly in from Alaska. However, and a lot of our providers have licensing in Alaska. It depends. So it depends on if our provider has a license in the state you're in. If you're in Washington State, yes, absolutely. Depends on where you're at. You are going to need some monitoring during your cycle, but it is something that you would be able to discuss with your provider what's the best and where you can go. Sometimes you can do ultrasounds or lab work at a clinic that's closer to you. Not all clinics are great about fertility ultrasounds, but we can find a place or have you travel to our clinic during the time of an IVF cycle or something like that. Okay. And did I see?
I see a couple finance ones.
Okay, go for it.
Yeah, so I want to backtrack just a little bit. There was a question about financing. We don't actually have any in-house like financial aid packages or lender options, but we do have preferred lenders that we work with. So when you establish care with one of our providers, you'll also get an assigned financial counselor on your team, as well as a clinical coordinator, a nurse. And so your financial counselor will walk you through all your options as far as where to look for obtaining a loan, grants and scholarship resources. We're here to help you as much as possible and make it happen. But internally, we don't have any financing options. We would just direct you in the right way. And then I also saw a question about initial fertility assessment prices for a cis female. So, of course, there's the new patient consultation. The lab work can vary. An AMH blood draw, if you're just interested in seeing where your egg reserve level is $69 out of pocket. And then they also like to usually pair that with an antral follicle count ultrasound a lot of times, and that's $175 out of pocket. So between the $69 blood draw, the $175 for the ultrasound, I think that, you know, Ruby can say we probably get a pretty good idea of where to start.
Yeah, and we do offer what's called a fertility assessment for somebody that just wants to know what their egg supply looks like, and they're, you know, not interested in anything else at this point, or, you know, considering like egg freezing or something like that. What you can do is schedule an AMH, just a blood draw, and it's a hormone that's produced by the cells lining the eggs in the ovary, and it's one of the ways that we can indirectly measure your egg supply. We get that back usually in a couple days, and then we schedule with one of the nurse practitioners like myself for a phone call, and we call you with the results and say, you know, here's where you're at for your age, and then give you, you know, quick conversation about like what your goals are, what brought you in, things like that. And we can talk a little bit more about egg freezing if that's the direction you want to go, or any of our other questions you have. So that's like our like fertility evaluation kind of thing. If you just want to know about your egg supply, it certainly does not talk about everything fertility. So it doesn't tell us anything about uterine status or fallopian tube status or fertility of the partner or anything like that, but it gives some baseline information. Okay. Can a known sperm donor use their own insurance for testing? Good question. Annika.
So yes, with a known sperm donor, we do charge a $500 administrative fee on our end because there's a lot that goes into the coordination with using a known sperm donor. But a lot of the actual testing will get handled through a sperm bank, and our clinical team will help with that and coordinating all the appropriate testing to be completed and what to schedule. And so it would actually be whether or not the sperm bank would accept the donor's insurance for those services, or if they would require you as an intended parent to pay out of pocket for them. Mm-hmm. And on our end, we do charge the non-refundable $500 admin fee for doing the legwork of coordinating all of that for you.
Anything else? I think we have about 5 more minutes or so. King County STD clinic for known donors. That is a question for the sperm banks. So what happens when you have a known donor? You know, you have your initial visit to talk about everything with your doc, and then you get set up with your coordinating nurse, but also the donor team. And that's what the donor team does all day long, is they work with known donors and egg donors and sperm donors and gestational carriers. And for our sperm donors, all the initial testing and everything is done at Seattle Sperm Bank, or a clinic that's closest to the known donor. We've had out-of-state known donors. So if there's an appropriate sperm bank near them. So that is a good question for the sperm bank, if they would accept recent results. Now, a caveat to that though, FDA requires that all of our infectious disease testing be done within a week of collection. So that is where it's a little tricky. And oftentimes is done at the same time, like all in one day at the sperm bank. I know, so many little complications can be annoying sometimes. Cool. Well, if there's any last minute, we have a few more minutes, but it's a good group. We had lots of good questions today.